Hello, my name's Dr. Leon Creaney. I wanted to talk to you about a sports medicine topic today, which will be of interest to many people, especially runners, namely patellofemoral pain. Just as I begin, I work predominantly in Manchester and Cheshire in the UK. These are the locations of my private practice and contact details. So, key questions I wanted to look at in this short lecture is: what is patellofemoral pain? How do we diagnose it? What, if any, is the relationship between patellofemoral pain and progression to osteoarthritis? What physical and psychological factors need to be considered? What do we think of the biomechanics? And then looking at a bit more detail about runners, which is a group I work with a lot. So, in terms of diagnosis of patellofemoral pain, people will normally experience anterior knee pain. It can be during exercise, but it's often worse afterwards, and people do tend to notice it when sitting with their knee bent, the so-called cinema sign. If people sit for a prolonged period of time, they tend to find that they have to get up and walk around. Subjectively, the pain can cause quads inhibition, and you can temporarily lose tone in the knee, causing the knee to give way, though this is a different kind of giving way to the true giving way that people get in ACL deficiency. It's often noticeable on stairs as it progresses, and people get damage to the chondral surface, crepitus or crunching can appear. And generally speaking, there's no other demonstrable pathology in the knee to account for the pain. So essentially, people with patellofemoral pain should have a normal looking MRI of the knee. Pain can be felt in quite a variable distribution. This was a study that asked people to draw where they felt their pain in patellofemoral pain, so it's anterior knee and particularly around the medial and lateral patellar facets. Various factors do predispose to patellofemoral pain. It is largely a biomechanical disorder of dis-ease of the patellar position and contact forces, and as a result, a patellar alta that sits too high or a patellar baja that sits too low are predisposing factors. The depth of the femoral trochlea is important, and a shallow femoral trochlea will of course predispose to patellar instability. So when we take MRI measurements of the above, we're interested in the tibial tubercle to trochlear groove distance. If it's too high, this is certainly a risk factor. Lateral patellar tracking dynamically, the so-called J sign clinically. The quadriceps angle, which is obviously higher in females, and things like the patellar position. And what we can see here is maltracking is clearly an important phenomena. Although there is huge overlap with normal knees, there is a tendency for people with more extreme lateral patellar tracking to suffer from more patellofemoral pain. Hip control is important in patellofemoral pain in comparison with asymptomatic subjects. There are abnormalities around the hip control in people with patellofemoral pain, and they tend to collapse their knee into valgus more dynamically when running and walking. This is just further detail on that study there. And again, we can see how the hip adduction angle and angle of rotation and even rear foot eversion is different in subjects with patellofemoral pain compared to controls. This is a really interesting study where they looked at landing forces in people with patellofemoral pain, and what they discovered that there is indeed increased load on the medial aspect of the foot when landing from a jump in people with patellofemoral pain. They found 22% higher medial to lateral peak force during that jump. What they were able to do in this study was in fact introduce a intervention to improve that, with a resulting improvement in patellofemoral pain, and I'll show you those exercises later. What we can see again, looking at the reasons why people get patellofemoral pain, is there is evidence of increased patellofemoral contact forces during squats in people with patellofemoral pain. And we can see that as the knee drops deeper into flexion, that contact area and force does increase. So any intervention that reduces knee flexion may produce a change in pain. Now, as I've said earlier, people with patellofemoral pain generally have normal imaging in terms of MRI. So imaging is largely done to exclude other causes in patellofemoral pain. So just going into a few more imaging studies, this one was looking again with SPECT-CT in people with anterior knee pain. And we can see that you can actually grade severity. And in this paper, they actually showed that increased osteoblastic activity actually conferred a worse prognosis, and patients were less likely to respond to conservative treatment and need some kind of surgical intervention. And we can see even here the positive predictive value for non-response in the patella, and how it goes up with the worsening grade of CT SPECT severity, and the corresponding arthroscopy images there. You can see the worse appearances on the CT SPECT also correlate quite well with increased fibrillation of the actual cartilage on the arthroscopy images. Quick mention here of one study which showed that patellofemoral pain patients in this example, recreational runners, exhibited significantly higher patellar bone water content compared to controls. Again, further corroboration that increased contact force is at play in patellofemoral pain. And we can see in this particular study where somebody has, again, on the left, increased CT PET images showing a hotspot on the patella there, corresponding on MRI to an area of bone edema in the retropatellar surface. And then when they standardized those scores for the metabolic activity seen on imaging with pain, you can see there was a reasonable line of best fit there. There are somewhat more advanced MRI techniques that we can use to functionally image patellar cartilage. This is T1 row cartilage mapping at the patellofemoral joint, and the false colour mapping there corresponds to cartilage quality. So even before we see cartilage degradation on normal MRI, we can see how the proteoglycan and glycosaminoglycan content of patellar cartilage is changing, and obviously these are pre-osteoarthritis changes. And this is a T2 map of a patellofemoral joint that looks reasonably normal on the plain MRI, but if you look on the right there, you can see green cartilage where blue represents healthy. indicating early softening of the cartilage, which is now predisposed to injury. This is what we see in slightly more advanced cases. We can see the cartilage at the back of the kneecap is getting somewhat mottled now, and this appearance is known as chondromalacia patella. And if a surgeon was to go into that knee arthroscopically and push against the cartilage with the arthroscopy probe, it would be much softer than normal. Slightly more advanced chondromalacia patella now, and we can see a fissure in the cartilage, and we're progressing towards osteoarthritis now. Grade 3, where we're almost down to bone, and we're starting to see edema in the bone itself. And grade 4, full thickness cartilage loss. Essentially, we're now at the stage of patellofemoral osteoarthritis. So there is a relationship between the two conditions, though it's not certain that one condition has to progress to the other. But people with patellofemoral pain, if it's not corrected, certainly do have an increased risk of developing patellofemoral osteoarthritis. So a short summary there. Patellofemoral pain is pain caused by chronically increased contact force at the patellofemoral joint. This leads to increased osteoblastic activity with its associated inflammatory cytokine release and bony edema, which is believed to be the source of the pain in patellofemoral pain. Severe cases over time may progress to patellar cartilage damage and eventually cartilage destruction. So, moving on to management with an emphasis on running. What can we do to try and improve people with patellofemoral pain? So this was a survey done of physiotherapists looking at what techniques they advocate. You can see the more popular ones there being closed chain and open chain exercises, exercises specifically for the vastus medialis oblique, various stretches, orthotics and taping. We'll talk about some of these now. And one question of interest is, would you encourage patients to continue through the exercises if they were painful? Most people agreeing that they wouldn't, as you may aggravate pain sensitization in this condition if you encourage patients to exercise with pain. So these are some of the recommendations from the 2016 patellofemoral pain consensus statements. This was a retreat in Manchester. Exercise therapy being the gold standard, but a combination not just of knee strengthening exercises but also the hip. And there may be a role also for podiatric input and orthotics. This was an interesting study looking at the role of orthotics. We can see here the introduction of a orthotic did seem to reduce patellofemoral joint stress at some parts throughout the stance and increased it in others. What it did seem to do was delay the point at which that peak was reached. Another study using orthotics. They experimented with either lateral wedge or medial wedge and looked at the person running over a force platform. And we can see how pain intensity changed under the different conditions. So a potential role there for orthotics, it's very much a try it and see. It will work for some and not for others. In this study, we could see reductions in pain in up to 33%, which is certainly clinically relevant and useful, but it won't work for everyone. Psychology definitely has a role to play in patellofemoral pain. As with back pain, people with severe patellofemoral pain do have a tendency towards catastrophizing and fearing movements. So if these are issues in your patients, they need to be addressed as well, often before you can move on to introduce an exercise program. It can be a bit of a vicious circle sometimes, and it can be difficult to know which came first. That's somewhat academic in a sense, but if you do identify that a patient's pain appears to be disproportionate to the level of pathology, then this is an area that you do need to consider tackling with them. So, we said earlier that an exercise intervention is the gold standard. A typical exercise and intervention would look like this. This was a clinical trial where they used two exercise interventions as outlined there. A low intensity group and a high intensity group, and they showed quite clearly that the high intensity group who completed the exercise program had much better improvements in pain score. We can see there the experimental group that did the high intensity program had an improvement in 3.2 on the visual analog scale versus sorry, not an improvement of 3.2 to 0.7, whereas it was a poorer improvement, 3.7 to 2.6 in the control group. So overall, minus 2.5 for the experimental group, but only minus 1.1 for the control group, which you wouldn't consider clinically meaningful. So in other words, if you're going to prescribe an exercise program, the patient does have to see it through. And this was another rehabilitation program, this time incorporating both hip and knee exercises. Fairly standard hip exercises that most people should be able to master and do in a gym or even at home. And quite a more extensive knee exercise program there. It is quite full on. This would take some time, but it is proven to work. Now, coming on to some other things that you can try with people with patellofemoral pain. So, particularly in runners, step rate adjustment can be quite useful. So in this study, they had people running on a treadmill, and the treadmill was obviously moving at a constant speed. The belt was turning at a fixed rate. The patient, the runner, was asked to count their step rate and then take that figure, add 10%, and develop a new running rhythm at that higher rate. The reason it's done on a treadmill is so that the running speed can be fixed, and the only variable that you change is the step rate. Obviously, if the step rate goes up, then the stride length has to go down if you're running at a constant speed. The result of that reduced step length is reduced knee flexion and less patellofemoral contact force. And we can see here at the enhanced step rate how the patellofemoral contact force improved, it reduced, and obviously that will lead over time to improvements in pain. So the take-home message here is a reasonable adjustment in step rate, which most people will be able to achieve, did produce a reduction in patellofemoral contact forces, which presumably will lead to an improvement in pain. And another strategy that can be employed and tried with people is changing their running style from rear foot striking to forefoot striking. Again, over a few weeks, a person with practice can change their running style. And again, we can see how when you change from the rear foot striking style to forefoot striking, how the patellofemoral contact force decreases and also the patellofemoral joint stress. This was done in a patellofemoral pain trial with 16 runners with significant improvements in knee pain after the intervention. We haven't so far talked about foot and ankle exercises. We've talked about hip and knee, but this trial addressed them. We can see the various foot and ankle exercises that were used. Exercises for tibialis posterior, wobble board, calf raises, and even intrinsic foot muscle exercises. Quite simple exercises that most people can do, and again, this improved patients' patellofemoral pain experience. McConnell taping is well known. I'm not going to review the evidence behind it. It's something that most therapists will try with their patients. It either works or it doesn't, and there is a very individual response. It's definitely worth a try with people, and they can usually learn how to do the knee taping themselves. Quadriceps strengthening has received a lot of attention over the years. It certainly works. It can be very difficult to increase the strength of vastus medialis relative to vastus lateralis, but this can be done using techniques such as muscle stimulation with electrical signals. So it's always important to strengthen the quadriceps. In extreme cases, people have tried botulinum toxin injected into the vastus lateralis. This is to functionally glide the patella in a more medial direction. And again, you can see improvements in knee pain following this intervention. Obviously, Botox does wear off again after a few months. But hopefully by that time point the new motor pattern has solidified and it leads to permanent change in muscle behaviour. Blood flow restricted training. This can be very useful in people who have a lot of knee pain and can't do a significant enough 1 repetition max to produce hypertrophy. If you introduce blood flow restricted training, you can induce hypertrophy at much lower training loads, so that can certainly be useful in a subgroup of patients. So in summary, patellofemoral pain is due to increased contact forces at the patellofemoral joint, leading to subclinical bone marrow edema and bruising with the resulting experience of anterior knee pain. Increased patellofemoral contact force is usually due to faulty running biomechanics and underlying anatomical issues. It can be improved with an exercise program. It can be improved by changing step rate, running style from rear foot to forefoot, training up hip, knee, foot and ankle, and also with McConnell taping and orthotics. In extreme cases, we do use Botox injections and blood flow restriction training. I hope that's been helpful for you today. And just to summarise, my name is Dr. Leon Creaney. I'm a consultant in sport and exercise medicine in Manchester, UK, and I am continuing to see patients during COVID-19.